right, I think we'll start. We've got quite a tight deadline this morning. Thank you for joining us. I introduce myself. My name is Les Jones and I'm a business development manager with Careflex. With me today is Rebecca Dunstall, our clinical lead. Helping on the technical side of things, unseen, is Kim Parry. Kim will be dealing with any questions. Hopefully we won't have any technical difficulties, but if you want to post stuff into the chat feature, we'll endeavour to come back to you as quickly as we can. Our guest speaker for the day, this is the first time we've had this kind of format, is Sarah Clayton of Simple Stuff Works. In all of our training sessions, naturally, as a supplier of specialist seating, we tend to focus on specialist seating. But we're always very aware of the effects of 24-hour postural care. We always mention this. So we thought it's about time we looked into this in a little bit more depth. So Sarah will be joining us in about 20-25 minutes to give us the kind of more in-depth overview of 24-hour postural care.
Specifically lying postures. So.
Yeah. So the format will be a little bit of a PowerPoint presentation to start with ourselves, and Rebecca's just going to go off to go load that up. Then we'll come back and look at a little case study with one of the chairs. Then we'll hand across to Sarah for the 24-hour postural management overview. As I said, we'll endeavour at the end, if we have time, to answer as many questions as we can. But if we can't, if you just want to use the chat feature, we will come back to you with emails over the next couple of days. And just for those latecomers as well, just to let you know that we will be sending out copies of the presentation. We're also being filmed as well. And if I could ask you all to mute and to turn off your video streams, that would really help the flow of the presentation. So I'll just hand you across to Rebecca, and I'll catch you in about 15-20 minutes.
Thank you, Les. As Les said, my name's Rebecca. I am clinical specialist at Careflex. I'm a physiotherapist by background. I was fortunate enough that I specialised straight away into learning disabilities and neurology. So postural management has really been the key objective of mine with my clients throughout my clinical practice, and that's where my passion for specialist seating comes from. What we wanted to do, first of all, was to just really set the scene around 24-hour postural management. Les and myself will then go into really the top hints and tips for achieving good seated posture and how specialist seating can help. And then we'll pass over to Sarah then, and Sarah can introduce herself, and we'll link that then with lying postures, so we can get a really good overview of why 24-hour posture management is so important and how we can address all those aspects. Hopefully everyone can see now the presentation as a full screen. Brilliant. Okay, so let's begin by just reviewing what is posture. Now, posture itself is quite a complex topic. So to help us to understand this, we break it down into manageable proportions. We can look at it as a system of body segments. You can see that image there. And posture is essentially the position of one or more of those body segments in relation to one another, but also their orientation in space. Now, postural challenges. As we grow and develop, we learn from and respond to information that's sent from various different sources, such as visual, vestibular systems, proprioceptive input. But damage to any of these systems, either through injury, illness, disability, or disease, like we might see in some of the clients that we work with, can affect the ability to interact with that information. And individuals will then find it increasingly difficult to achieve good and protective sitting and lying postures. Now, postural care is the holistic use of any technique to minimise postural abnormality whilst enhancing functional movement. Now, it's an approach that aims to preserve and even restore body shape for individuals, for our clients who may present with movement difficulties. For example, people with profound and multiple learning disabilities often sit and lie in restricted positions, which can lead them to a high risk of postural deterioration. Now, there's been recent publications and guidelines that thankfully have been published around this. And one thing that was highlighted was that body distortion is not inevitable. And by prescribing the right equipment and positioning techniques, we can actually help to protect our client's body shape. Postural care will address all those body segments and positions that an individual adopts throughout the day and night. And it usually involves an individualized 24-hour program that can include the provision of seating, positioning equipment to support them in lying, moving and handling techniques, but also advice and training for their support network, for carers and for loved ones as well, across all settings, because it's important that any programs or management plans that are in place are then used consistently and people are compliant with them to ensure that we get the best outcome. It's a multidisciplinary approach that will encompass a person's daily life, and we need to ensure that we respect all activities and interventions that will impact on their posture and function. And that's where that term holistic comes in, to make sure that we're getting that compliance and consistent use. Because if it doesn't fit into daily life for them, if we are not enabling them, then they're simply not going to follow that management plan, and we're not going to achieve our clinical objectives. So it must be considered on an individual basis, following a comprehensive postural assessment and goal planning. And then those interventions should be regularly reviewed to ensure that they continue to meet the individual's needs, just in case there is a regression or even a progression where we need to adjust some of those interventions. So why is it so important? Well, posture is directly related to an individual's health, well-being and quality of life. There are going to be physical, psychological and emotional effects of body distortion, and poor postural care can have severe and life-threatening consequences. An individual who sits or lies in unsupported and or asymmetrical postures can experience pain, fatigue, dependency, increased equipment needs, and also poor physiological function. And gravity and its effects can also trap individuals in these destructive postures as well, further exaggerating asymmetries and leading to unequal loading on tissues. Now, failure to protect our client's body shape can result in many health complications, and the aim of providing that 24-hour postural management will help to reduce those health risks and hopefully improve quality of life for them, which is why we essentially do what we do. But it can also benefit those caring for them or supporting them too. This inability to sit out comfortably can result in individuals becoming confined to their bed with limited interaction engagement, of course, impacting on their social isolation and their well-being. But equally, the lack of appropriate lying support can restrict their ability to achieve good sitting posture. So this is how lying and sitting postures are so interlinked. And hopefully, as we move through this session, you'll understand then how one can impact on the other as we transition over to Sarah's side of the presentation. So who needs postural care? So we need to think about identifying those who are at risk, because it's always best to implement these postural care pathways or programs as early as possible and in a timely manner. So we need to think holistically when identifying those who might have difficulty achieving good posture in sitting, in lying, and all other dynamic postures as well throughout that 24 hours. And I know that Sarah will be sharing some hints and tips and some useful resources to help you objectively identify those individuals and help determine if they should be on a specific pathway as well. And I know that Sarah mentioned about sharing those resources with you when we sent out the presentations. But ultimately, we need to think about those who lack the physical ability to change position, those who lack the cognitive awareness to know that they need to change position, but also those who lack the communication skills to convey that they need to change position. Postural care must be proactive as well. So there was, in 2013, a confidential inquiry into premature death of people with LD, and they established a link between a failure to protect body shape and premature death. And a key issue that was identified in this review that made people particularly vulnerable to premature death was the inattention given to predicting potential problems. So a particular area where there was a lack of that forward planning was in postural care, and it was recommended that clinical commissioning groups should ensure that they commission expert preventative services, including proactive postural care support. So there's some really useful researches and publications and guidance out there that you can use as part of your clinical justifications as well, as part of your funding requests, to really add the clinical justification for that. And give some power to your request, to your equipment request. But it's also just highlighting how vital it is to actually people's health and well-being that we identify those at risk and we get postural care in a timely manner. Now, moving on to sitting posture. So, of course, as I said, that's what we are focusing on our part today, on specialist seating. Those of you who have an interest in seating will no doubt have heard of Pauline Pope, but she broke it down into these very basic checklists. So when we're achieving good sitting posture or supportive sitting postures, the body is conformed to the supporting surface as symmetrically as possible. Body weight is distributed equally over the maximum surface area. The body is able to adjust to change depending on the activity, such as reaching outside of the base of support, whilst remaining balanced and stable within the chair. Body segments are supported and aligned as much as possible, but then the upper limbs are also free from the load-bearing role to enable that functional independence. That's a key part of postural management. So when we achieve appropriate sitting postures, we'll be facilitating that functional performance and independence. Our clients will be energy efficient, so they won't be fatiguing quickly within the chair. So hopefully we will be enabling activities of daily living and that engagement within daily life. But we'll also be protecting the body shape, which is obviously a key part of postural management that we've mentioned, reducing the risk of those secondary complications and not harming any of the body systems or segments. So visually, I just wanted to show you, obviously, that this is a gold standard and it's not going to be achievable when we're working with some of our really complex cases, but we should still be aiming for our clients, for the individual's optimum sitting position. But just be mindful, and we always hand this over, that it's not about achieving that one perfect posture. Sometimes there's a balance, there's a compromise between achieving a good, comfortable, supported position, but encouraging that regular change as well. And you do that through use of different chair functions, and we'll have a look at that in a bit more detail when we run through a case study shortly. But essentially, we're trying to achieve that checklist of having a supported, upright, symmetrical head and trunk. The pelvis is supported at the back of the chair and remains stable. The arms supported at the correct height, but they're still free to be able to engage in activities of daily living. They're not there to support the trunk or stabilise the body. The thighs are midline, and of course the lower legs and feet fully supported. And sometimes the feet can be often overlooked, especially within seating. Typically, we associate it with it being a load-bearing body segment, but actually within seating it is critical for that pelvic stability. We naturally seek support through our feet, and we need to get that stability through to our pelvis to be able to remain dynamic in that posture, but also remain functional as well. 19% of our body weight goes through our feet in sitting, so we need to be mindful of that.
Yeah, and we'll see it a little bit more when we look at Callum's case study a little bit later. One of the key things was foot support, or the lack of it in his existing chair.
Now, I just wanted to quickly recap. I appreciate there's a lot of information here, and as we said, we send out these presentations. There's also a lot of information on our website as well. There's an info hub on there with a lot of clinical resources, articles, a bit more detail about some of these postural challenges and the seating solutions. But I just wanted to highlight some of the most common ones that you might be presented with your clients. Posterior pelvic tilt, probably that's one of the most common postures that we come across in sitting.
You'd see it in most nursing homes you would have walked into this morning anywhere in the UK. Yeah,
that sacral sitting, gravity, especially if our clients have generalized weakness or poor postural control and pelvic instability, gravity pulling them down into that sacral sitting. Can be caused by other things as well, other intrinsic causes such as limited hip flexion, tight hamstrings, weak abdominals. even down to the actual setup of the chair itself. So even without any damage to the body systems, if the chair dimensions, the basic chair dimensions aren't set up for the user, for example, if the seat depth is too long, then we will be actually causing this posterior pelvic tilt because they need to slide down the chair to be able to get their feet onto the floor, to be able to flex their knees over the edge of the cushion. So it's one thing Les will always say, is all those finer details, the devil's in the detail. We need to get that chair set up for the individual user, seat width, seat depth, seat height, and so on. Posterior pelvic tilt can often be associated with an increased thoracic kyphosis, as you can see in that image. Cervical spine hyperextension, because they're trying to maintain that functional visual field, and a tendency to slide forward within that seat. And then we could see an increased risk of pressure injuries over the sacrum and the apex of that kyphotic spine. Then we have an anterior pelvic tilt. So a posterior pelvic tilt is when the ASASs, the anterior superior iliac spines of the pelvis, are, you see on the image there. If I go back, sorry, the posterior pelvic tilt, you can see the difference there. So the pelvis is tilting backwards. A anterior pelvic tilt, where the ASASs are then lower than the PSISs because they're tilting forwards. Anterior pelvic tilt, you might see in extensor patterns of activity, maybe individuals with neurological impairments or involuntary movements. There could also be tight paraspinal muscles or increased lumbar lordosis, or even obesity, causing them to go into that position to relieve pressure on the abdomen. It can be associated with a reduced functional reach as well. Pelvic obliquity, where one ASIS is higher than the other, caused by things like an asymmetrical trunk, scoliosis, abnormal muscle tone, limited range of movement at one hip, and even fatigue as well, again causing gravity to pull them into that position. It's often associated with a pelvic rotation, where one side of the pelvis is more forward than the other, as you can see in the image. And we need to be mindful of these pelvic instability, because the foundation for sitting is to stabilize the pelvis, because it dictates what happens above and below. So whenever we do our assessments, we always take it back to the pelvis to get that pelvic stability, and then we move through the body segments. An increased thoracic kyphosis. This is when an individual presents with an increased curvature of the thoracic region of the spine, and you'll see a more rounded position at the top of the back. Can be associated with a posterior pelvic tilt, as we mentioned, scoliosis, and an increased risk of pressure injuries. Quite a difficult posture as well, because of the head position, to be able to maintain a line of vision for engagement and interaction, but also physiological function as well, to enable good swallow, safe swallowing, and respiration, to be able to open up the shoulder girdle. Scoliosis is where you might see the spine twist and curve to the side, a C shape or an S shape. In sitting, you might see them leaning to one side, their shoulders might be uneven, or you may even see protruding of ribs on one side, as well, as you can see in that image. Again, associated with physiological dysfunction, respiratory problems, digestive problems, and so on. And then we have wind sweeping. This is my lovely sister's legs who modelled for me. But as you can see, there is an abduction and external rotation of one hip, with the adduction and internal rotation of the other hip. And it's termed according to which side of the body the lower limbs are wind sweeping. And it gives the impression they've been swept to one side within the chair. Can be associated with a pelvic obliquity, a scoliosis, a rotation with a spinal rotation, and even a posterior pelvic tilt. Then we have contractures, which is a clinical term that's defined as a limitation in passive range of movement at a particular joint. It is a complex and multifactorial diagnosis with a number of structures involved, such as the joint capsule, the ligaments, muscles, tendons, and skin. Unfortunately, this type of postural challenge is where we then see more complex cases, and we'll see in the case study shortly with Callum's story, where we're trying to protect that body shape to reduce the risk of those contractures worsening, because once bone is involved, they're typically irreversible, and that takes us back to identifying risk to ensure that we are managing that posture and protecting that body shape. So Callum's story then. We've got a 20-year-old gentleman with spastic quadriplegic cerebral palsy and epilepsy. He'd had previous surgery for spinal rods with pelvic fusion, which was deemed successful. He was a wheelchair user, hoisted, communicated through eye movement, and lived at home with a supportive family, but attended college 5 days a week. His postural challenges were fatigue, discomfort, pelvic instability, involuntary movements, including a strong extensor thrust, asymmetrical trunk will lean into one side, a leg length discrepancy in the lower legs. So he was at risk of further postural deterioration, increased risk of pressure injuries, illness, social isolation, above all as poor quality of life. And for Callum, it was mainly interacting with family, wasn't it, within the home?
Yeah, it was, yeah. And have we seen the image?
Yeah, so I'll just show you again the before image there. You can see
the before
Callum.
image, you can see the lack of foot support,
Yeah.
The lack of seat depth adjustment. Just wasn't, and this was a measured for prescribed bit of equipment. But the after shot there says it all to a certain extent. So perhaps if I just run through the chair.
Yeah.
I'm conscious of time, so this will be a quick fly through, if you like, of the product and what we did on the assessment for Callum. So the chair we use is a chair called the Smart Seat Pro, which is a tilt and space chair with back angle recline. The first thing we identified was foot support. Callum was really struggling in his existing chair to get that feedback.
And what we were seeing was that increased extensor thrust then, because he was lacking that stability within the chair, and then that was impacting on his comfort levels, because he was getting spasticity and he was getting pain related to that, but also his function as well in interaction within the home.
So on the Pro, we've got an elevating leg rest which articulates. I just want to quickly show you what I'm trying to explain here is that this section here extends as we elevate the leg rest. With the foot plate, if that didn't happen, it would have the effect of lifting Callum's legs off, or Callum's upper legs off the seat surface as we elevate the leg rest. It's also angle adjustable, and we can extend that in length. Okay. One thing we needed for Callum, though, was he tended to display his feet and they were coming off the side of the foot plate. So we added a foot plate pad. Nice and soft, and just give us a little bit of a guide to keep his feet nice and firmly on the foot plate. We did need to angle adjust. If Callum had been a little bit taller, we could extend the leg rest or decrease the leg rest to make sure that he could plant his feet quite firmly on the foot plate.
Another key thing for his foot stability was the stepped foot plate pad as well, because of his leg length discrepancy. So that was part of a tailored seating solution.
Yeah. So what I'm showing you at the moment is pretty much off the shelf, but there were some bespoke components to Callum's chair, which meant, that limb length discrepancy. We built up one side of the foot plate to support and to provide a little bit of feedback for him. Pelvic stability, we can adjust the seat width and the seat depth on this chair. So obviously Callum's a young lad. We needed to future-proof things. So you can see there how easily I can adjust the seat width on this chair. Very quickly, just pulling the tab at the back, hand on the outside, and just moving the side in to give us the required seat width. The seat depth, again, we adjusted for Callum, a little bit like your car seat. You squeeze the bars together, bring it away, or bring it closer to me to increase the seat depth, and away from me to decrease the seat depth.
This was really key for his involuntary movements and extensive thrust. Getting that pelvic stability really did help on review. Family mentioned that it did really help to manage and dampen down some of those abnormal movements for him.
A little bit of use of tilt and space.
Yeah,
the chair's got back angle recline, but we didn't really need that for Callum. You can see the back section here, 4-section multi-adjustable back. And what that means is that you're able to adjust each section specifically for the person sitting in the chair. So for Callum, I show you the slider on. Just loosen that off. We needed to bring the top section slightly further forward for him.
For postural management, we were correcting where we could, but then using the chair to accommodate then any fixed postures that had unfortunately become irreversible.
We could bring the wings in. We can do this in each section with the head section, just enough to give him a little bit of head support without kind of impairing any kind of peripheral vision. And each section can be done the same way. Lateral support, we've got built-in laterals, but we needed something a little bit extra. So we just folded the built-in lateral away. I just added an adjustable lateral to the back of the chair. And I bring the existing back just to give him some support behind the arm. You've got the head, shoulder, thoracic, and lumbar. We're able to just adjust each section and twist, so to help with that limb length discrepancy and a slight rotation, we were able to just twist the lumbar section forward on his right, just to give him that little bit of support and to fill that gap.
Is again taking it back to the checklist for a supportive seating posture. We need to make sure that, as Les said, filling in those gaps, and we need to get each of those body segments supported within the chair, but also over the maximum surface area, so that we're distributing that weight equally as well to bring in elements of pressure care.
And that really was, I've kind of really flown through that little part of the presentation there. You get a lot more detail on the handouts that we send to you. So I'm just aware of time, and I think it's time that we hand over to our guest.
Yeah, and as we mentioned, I run through, again, there's a lot of information in terms of some of the common postural challenges in sitting on our website. They're on the info hub section, and it actually goes into detail then about some of the seating solutions that can help, or if you want to get in touch with us about any specific client challenges as well. Okay. Let's make Sarah a co-host. So Sarah can enter.
Thank you.
Oh, there we go.
Welcome, Sarah.
Hi, Sarah.
Thank you so much. Thank you. So thank you, Les, and to Rebecca for inviting me today and for that presentation. And it's almost like we planned it, but it just seems to fit mine perfectly. So hopefully I will be able to share my screen. And there we go. So Les, can you see my screen?
Yeah, that's fine.
Very good.
Brilliant.
We're good to go. Okay, so we're just going to really quickly run through some ideas around positioning in bed, because we all know that people's disability impacts them 24 hours a day. So we need to be aware 24 hours a day of how an individual is being positioned, how they're being supported, common risk factors, things like that. And we don't have very long. There's some information that will come out to you around courses and things like that that we run in collaboration with an organisation called Born at the Right Time, which kind of we're looking at 3 days of CPD certified training here, kind of condensed down into kind of as short as possible. So just to introduce myself, my name is Sarah Clayton and I'm Chief Executive at Simple Stuff Works. I am also the oldest daughter of John and Liz Goldsmith. So some of you may know the Goldsmith indices of body symmetry. And my mum and dad, so I've grown up in a house where postural care was what we talked about in the evenings over Sunday lunch. You know, my mum worked she calls herself a recovering physiotherapist, and worked for a number of years in an institution and then in the community. And that's where, kind of her real sort of formative years as a physiotherapists supporting people with learning disabilities was spent in an institution, and we would go there after, if school was closed and things like that. And what she says was her huge privilege was the fact that sorry, Martha says, is anyone else freezing? I'm not sure. I don't know. So her huge privilege was the fact that she was able to see in front of her a great many individuals, all of whom were experiencing changes in their body shape. And so she was able to see the patterns of distortion as they were, as in the presentation, not temperature, but you're back now, I think. Oh, okay. So I was thinking, I don't know, we could all turn the heating up. I hope that I am back with you, and I hope that it's not at my end. So I'm also the wife of one, the mum of four, and my oldest daughter, who you can see there with me, has a complex brain injury following a cancer diagnosis when she was 6 years old. I'm not a therapist, I'm a biologist. So my training, I have a biology degree, I have a postgrad teaching certificate, and but all of that, I've worked since 1998 supporting people to understand the lying position. So that's what I've done for 20 odd years. So who needs support in bed? There's a brilliant paper by Jackie Casey, and I will send the link when the information comes out to you. And what we tend to think of is that we're thinking of children and adults who have the most complex disability, the most restriction on their movement. And it's those individuals that we need to think about support in bed. And we've been getting it wrong for years and years and years. And deep down, we all know that, because we know that postural distortion, and Jackie's work recently, she published a paper last year, postural asymmetry occurs in looking at children, from GMFCS 1 right the way through to 5. So we need to be thinking about, how does an individual's body, we need to separate form and function, because a person's body shape does not necessarily, their function's not necessarily the best indicator with regards to their risk for developing changes in their body shape. So we need to get better at identifying those individuals who may need some more postural support. When we think about older people, and I'm going to talk a little bit about a Belgian therapist called Jo de Klerk, who shared this gallery with me. This gallery is brilliant, the Arjo Gallery. It's absolutely fantastic because it helps us. It's great to, we can all understand who it is that we're talking about. If you give, Rebecca a call, or you give Les a call and you say, I've somebody, rather than going through lots and lots of descriptions, we can talk about Doris. It gives us a shorthand to think, oh yeah, I know who we're thinking of. And when we think about Albert, Barbara, Carl, Doris, and Emma, again, when we think about support in bed, we tend to be thinking about Emma. We're too late to the party. And often when we think about Emma, we're too late even for Emma, because we're starting to think, oh, Emma's struggling to sit out. We might need to look at her positioning. Barbara was who you needed to be thinking about. Okay, as soon as somebody starts to develop any sort of hip and knee flexion, not necessarily contracture, but as soon as people start to reduce their mobility significantly, then we need to start thinking about how are they being supported in bed. So Jo de Klerk is a Belgian therapist, and we, as I say, we haven't got time to go into his work in great detail here, but what he does is he helps people to understand how the brain impacts on the body, and how the body signals to us, lets us know what the brain needs in order to meet that person's needs. So when we think about, and it's a term, if you look up the term paratonia is abnormal muscle tone that's associated with a lack of proprioception and balance. Okay, so we're not thinking about, we have to be very careful when we're thinking about the term contracture, as to whether what we're looking at is a contracture or what we're looking at is a posture that's being adopted because we're not providing enough support for the person's body in order to give their brain what they need. So his work is absolutely superb, and it has huge implications for the use of alternating airflow. Okay, so like I say, we haven't got time to go into it today, but there's so much out there around the lying position. See, I get myself really excited and then I get out of breath. The Mansfield checklist. These are the first tool that I want to introduce you to, because who are we thinking about? And it can be really difficult, can't it, to you know, kind of who are the people? You're saying that we're too late to this, but who are the people that we need to be thinking of? So the first paper I ever published was the Mansfield project, which was in 2000. Like I say, I'm a Goldsmith, and then I was a Hill, and now I'm a Clayton, and I've published under all of those names. But the Mansfield project, within that, I developed a checklist, which is really simple. And it's just 6 questions. So does the body stay in a limited number of positions? Yes or no? Do their knees seem to be drawn to one side, or inwards or outwards? Yes or no? And when we do a full Mansfield checklist, what we'll do is we'll just have a couple of lines underneath that explain, you know, does the body stay in a limited number of positions? Yes. And then explain what that position is, you know. Are their arms and hands in a position in which they could function normally? Yes or no? Does the head seem to turn mainly to one side, to the right, to the left? Does the body tend to extend backwards, flex forwards, to the right or to the left? And then the catch-all, and this is where we start to think about widening the net a little bit in terms of making sure that we are supporting everybody that needs support. Is the person's body shape already asymmetric? And I would say that, you know, with Rebecca's list of who are we thinking of, we also need to think about those people who are presenting with body asymmetry already, and they may not have those particular risk factors that you're looking for. So for example, I have worked with lots of individuals with autism. Now, they don't fit necessarily the traditional, you know, kind of profile of somebody that we would be thinking of for nighttime positioning, because their preferred lying postures, their limitations with regards to their lying postures tend to be sensory driven. So they don't necessarily fit that idea of an illness or a condition that is limiting their movement. It's a slightly different reason, but they're developing changes in their body shape as a result of those limited postures. So the Mansfield checklist, really simple to use. Okay, so, and you can have, you know, it's easy to use in care homes, it's easy to use on wards, it's easy to, you know, it's just dead easy. Quick screening tool to make sure that you're not missing people. So you've identified somebody that you think needs some support at nighttime. These are the sorts of things that we would be looking at during I've lost my power of speech, during an assessment. And we're not going to go into them all because we don't have time to go into them all. But how much time is people spending in different postures? Their bony markers, which we'll quickly have a look at. Posture analysis, which is another tool that's dead easy to use. Thinking about impact on function and thinking about pressure risk. And I have with regards to pressure risk, I'm not going to go into pressure risk, but what I will say is that we need to start having some pragmatic conversations around the use of particular pieces of equipment, and I'm thinking particularly about alternating airflow, that we're using as a so-called preventative measure. Because what we're often seeing when we think about people and supported lying, alternating airflow really limits the way that you're able to support somebody in lying. And what a common occurrence that we find is that people are being put onto alternating airflow. They may not have a pressure injury, but it's being done in order to address a perceived potential risk, but they already have existing body shape distortion. So rather than dealing with the problem that the person actually has, we are limiting our ability to deal with that problem in favor of a risk potentially in the future. So that's and I could talk to you about that for hours and hours, and we can go through the science behind it and all that sort of stuff, but we don't have time to do that. So what we're going to start thinking about is during our assessment, getting really familiar between the link between lying and sitting. Now, my party trick, and it's not a particularly impressive party trick, is to know from a person's seated posture, what their lying posture is, because it's just there in front of you. Thinking about time, if you know somebody well, this is from an organisation called Medifab, who we work with in Australia and New Zealand, and you can do it in 2 different ways. So it's a 24-hour clock, and all that you have to do is take a look and see, for each hour of the person's 24 hours, do they have the equipment that they need, and is the equipment effective? It is no good. We all know it's no good. We can't just say, oh, they have a seat. If the seat, you've just seen from the case study that Les and Rebecca shared, if it's not right, it's not right. You know, we need to be thinking, not only do they have the equipment, is the equipment the right equipment? But what you can also do is you can use that 24-hour clock to think about who is supporting this person. And when you've done that exercise, thinking about, do they have the equipment, and is it working? And then we can think about who, that gives you a priority list. Because if something is missing, a priority list, what I mean by a priority list is which pieces of equipment do we need to get sorted out, but also who do we need to train, support, coach in order to be able to use those pieces of equipment effectively. And I think that second one is something that we can often miss. Now, if you do analyse your 24-hour clock, what you tend to find is that there are 3 key pieces of equipment, and that's a wheelchair, alternative seating, and nighttime positioning. And if one of those is missing or isn't quite right, then you've got a big gaping hole that people will fall through. And I've been involved with work, as I said before, around reasonable adjustments, around leader, around premature death, those sorts of things. And those gaping holes that people fall through, changes in body shape limit the length of people's lives. They also limit the quality of people's lives. And very sadly, seeing individuals who experience completely avoidable body shape distortion is absolutely tragic when we think of what we know and what's available. So there's so much that we can do. Right, bony markers. The individual's lying in front of you, and we're looking to see, so usually in supine, we're looking to see what's going on with regards to the bony markers. If a person's knees, when we think about structural symmetry of the body, if you think about this individual and their knees are upright, if the person's knees are upright, their pelvis should be level. And so looking at their aces, those bony bits at the front of your pelvis, and their sternum should be central. So basic symmetry of structure. Okay, so that's what we start to look for. When the knees are upright, is the pelvis level? Is the sternum central? And if not, that's what starts to drive our equipment choices around what the person needs. So what I mean by that, I'll come back to you in just a second, because we'll get a full screen and I'll show you. In fact, let's very quickly, I'm going to come back to you. So do you have me? Hopefully you won't be able to see my screen anymore, but what you can see is my little skeleton. So what I just really quickly want to show you is, when you think about those bony markers and you think about chest shape, what we see is 2 types of distortion. We have compression distortions, where we squash the chest, or we might squash the chest like that if the person sleeps in side lying, or we have rotational distortion, okay, where we see the chest twisting. Now, neither of those is good, but what we need to do is we need to identify what's happening to the chest in order to work out what's our therapeutic intervention going to be. So if we have an individual who has a straightforward chest compression, then we know that our therapeutic intervention needs to be decompression. So we need to support the weight of the chest and hold that chest wall mass. Now you can do that with a lateral, like people talk about sleep systems, lying support systems. A lateral system will do that. If we're thinking about rotation, and if that's what you're looking at, then you need to think very carefully about which system you're going to use, because they don't all derotate. So we start to see how we need to tie the equipment choice back to the problem that the person is asking you to solve. Now, if we quickly come back to my presentation, hopefully you're all back there. So what you can see here, we can start to think about compression and about rotation. Individuals, when we think about individuals, sometimes you'll meet individuals who have contact between their rib and their pelvis, which is a very, very unpleasant situation to find yourself in. And the reason for that is because we end up with a chest that's both compressed and rotated. And when that happens, in somebody who with a symmetrical chest, we don't get contact between rib and pelvis. But in somebody whose chest is wider because they're compressed and rotated, then we can get that contact. So we need to, if we're going to, and you won't solve that problem in seating, you need to solve that problem in lying, but then you need your seating solution to keep up with you as you correct a person's body shape. So just quickly, this is how we derotate the chest in lying if rotation is the problem that we see. So here we've got clockwise rotation of the chest. There is his little sternum. We've got a rib flare starting to happen here. We're going to see a rib distortion on his back here, and we'll see a narrowing here between his lower ribs and his pelvis. So all in all, a bit of a disaster. So what we have to do in lying is derotate the chest and get the sternum back in the center. So we block this side of his body. We rotate him round until we get the sternum central. And here we can see the sternum is central. And what we can also see is that rib flare here has become really apparent. Now, if we don't have the, if we have to have the skills to explain that to parents and to caregivers, to explain what it is that we're doing. And because if I as a parent see that and nobody's explained to me and told me that's what's going to happen and this is what it means and this is what it's actually a good thing that we can see it because we can sort it, then I know that I would be frightened by that. And I know that no matter what you say to me, I'd be thinking, well, he looked better. He looked better before, so I'm going to keep doing what I was doing before. So we have to be looking about that education piece and that training and support, ongoing support for families. When we do get it right, when we are introducing the right forces, then we will correct body shape in lying. Lying and seating, the biomechanics are different, and it's important that what we don't try to do is replicate a seating solution in lying, because they're different forces, and when used effectively, then we can look at correction. So this young man is 25 years old, and I made a quick note here as Les and Rebecca were talking. If you look at the correction that we've got for this young man within 3 months, what's fantastic about what Les and Rebecca were talking about and showing you with regards to the seating solution is the adaptability of the seating solution, because the seating solution can keep up with the therapeutic intervention. If you don't have a modular adjustable seating solution, then you end up in the situation that this young man ended up in, which is where we're correcting his body shape, but we had an absolute disaster with regards to the equipment that he was using, because it was all custom contour, and trying to get yourself back into a system in order to get things recast, all of that sort of stuff. It was a complete disaster. So on the one hand, brilliant news, those photographs are fantastic. Think about the improved lung function, think about comfort, think about long-term health implications of sorting out that scoliosis, but the equipment solution isn't keeping up. Okay, wind sweeping. So wind sweeping, Rebecca mentioned earlier, wind sweeping is a whole body system. So we need to think not just about what happens to the legs and the pelvis, we need to also think about what happens to the chest. So wind sweeping as a whole body distortion requires a whole body solution. And one of the risks that we see is that people think, oh, this person is windswept, I just need something for their legs. It's a very, very commonly held misconception. Okay, so we need to be thinking, if you have an individual who is wind sweeping, just think to yourself, don't fall into the trap of thinking this is just about their legs. This is about their legs, their pelvis, and their chest, and I need to provide an immersive solution for the whole of the person's body. Again, bony markers, you need to be looking for the gap at the waist. A really nice way of doing that is using hair ribbon. So you can, when the person's lying down, if you're wanting to explain to, again, a parent, a caregiver, what you can see, then hair ribbon across the lower ribs and across the pelvis, you can start to see whether we're getting any narrowing. And if we are, then we know that we've got some rotation, and we know that we need to provide some derotation. So, you start to see how the lying position ties in with the seated posture. The last two things we're going to look at very quickly. Posture analysis is a very simple tool. You start at the head and you work down, and I'm going to share the posture analysis tool when it will come out to you in the email. Start at the top, go down to the bottom. You can teach people to do this so that they can start to see. One of the risks that we have is that people think it's either a destructive position or it's a perfect position. And it's really rare that we'll get somebody into an absolutely perfect position who was in a destructive position previously. But what we do need to help people to see is this is an improved position from where we were. And it might not be perfect, but what we're going for is progress, not perfection. Okay, and we can work towards perfection, and we'll get there in the end. But unless people feel and can see that they're making progress, then they can, it's hard to maintain that motivation to keep going and looking at the lying posture, because nighttime's also a time when people would possibly prefer to be fast asleep than, faffing about with nighttime positioning. Which leads me nicely on to with the goal setting and goal sharing and all of that sort of stuff. You have to be realistic for nighttime. You have to be understanding that nighttime is a really complex, having been the person who's got their daughter being NG fed next to them, who is awake through the night thinking of all the what ifs and all of that sort of stuff. Nighttime's a lonely time, and we just need to be very sensitive about how we introduce changes at night. So if you think about, this is a young man called Elijah. So if we think about his position, and then we think about this position, what you can see is that we've got two completely different posture analysis. Okay, so it's just a simple tool. Is this position better than the other one that we were in previously? No, it might not be perfect, but is it progress? So finally, why we need to get a grip on positioning in bed, because the way you lie is the way you sit, and the way you sit often dictates what you can do, how you feel, what you can enjoy, and the extent to which we can participate. Lying is absolutely the root of so many keys to life, and we kind of ignore it at our peril. And gravity, sadly, is relentless. So lying provides huge opportunity, but it also provides huge challenges, because as I said before, it's a tricky old time, but if we can get it right, it really is powerful. So this paper was written by Melanie Stevens and et al. Co-workers. The impact of nighttime positioning equipment and staff training on posture and quality of life of adult residents living in a community residential home. And I'm not going to go through the whole lot. The results were phenomenal. 12-week study, things like a 50% reduction in choke risk. All right, things, improved communication, improved nutrition, all sorts of stuff. The paper, just Google it. It's around, or I can send it out with you with the information. And just some before and afters, really. Everyone loves a before and after. Bearing in mind that we're talking about 12 weeks. Okay, this lady was unable to sit out, and that was causing huge problems between this lady's family and the care home. Because they felt very strongly that she should be sitting out, but the care home would explain that it was not physically possible. So 12 weeks worth of nighttime positioning or supported lying, and we get to a stage where she is able to sit out again. Not just improvements for her, but improvements for the relationship between the care home and the family. And then finally, 12 weeks, so it's a huge, just everything about this has the potential to be beneficial. And I'm going to leave you with my youngest, just to say the way you lie is the way you sit. And it's just a game, little party trick. Which of these lying positions will result in that seated posture? Okay, there's only one of them. And it's a jigsaw puzzle, isn't it? If the two positions don't match, if the lying position doesn't match the seated posture, at some point your seated posture, you're not going to be able to make that journey anymore. Okay, the lying posture always wins. So the way you lie is the way you sit. Measure body symmetry. Key considerations: sweat and sleep go hand in hand. Huge periods of time. The equipment needs to be flexible. The idea of custom contour night positioning, which occasionally kind of seems to rear its head, just feels very tricky to me after 20 odd years of doing this. Get in there early and you will minimize the problems that people face. You have to have clear shared goals with the person and their family, and you also need clear monitoring, because people like me who are juggling lots of caring balls need to know the impact of what you're asking us to do. And these are just some people. This list is like my they're just amazing people, you know, so brilliant people in this field. Check them out. There is some fantastic work out there. And I think that is me all done. I shall stop sharing. Is there a point? So just a quick question we've got, is there a point at which we cannot correct posture? Yes, absolutely. Yeah. And the ambition is that we get in there before that. So yes, there does come to a point where with structural bony changes, people will become very complicated. It's not just the structural bony changes though. If you think about somebody with a chest distortion like that, and for a while we may be able to derotate them, but there will come a point where their structure will impact, for example, the way that the person breathes. Mm-hmm. Now, if we've got to that point, and then when we introduce our clever newfangled position, it turns out that the person's then unable to breathe, that's another way that we could end up where we're simply unable to correct that posture, because the therapeutic position required is too risky for that person. And the other thing is that if you've put metalwork into somebody's body, that massively restricts the way that we can position that individual. So there's lots of limitations. The idea is that we start getting in there earlier.
Identifying that risk.
Totally. Yeah. And it starts, so early intervention, pediatrics. So say for my daughter was diagnosed at 6. So her early intervention should have been just after she had her brain surgery. It wasn't. It was because I'm her mom. So on a specialist neuro ward, she was the only child that was using nighttime positioning. Everybody else was going from side to side because of a pressure, because of a perceived pressure risk. So we will side lie, and there's a huge amount of work to do with regards to training. Yeah. But yeah, is that okay?
Yeah.
Brilliant. Thank you, Sarah.
Talking of limitations, I think we've reached 12 hours, and that's time.
Sadly.
Thank you, Sarah. It's really
been okay.
Insightful, and thanks to Rebecca as well. I've had the easy bit, really, to be honest. Just to reassure people, if you have asked a question, we will get back to you. We will respond to these individually. Just a couple of things, just having viewed, it's really interesting. Really, I think what we're talking about is a kind of joined up, holistic approach.
Definitely.
To a lot of the issues that we need to resolve for somebody. So it's really thought-provoking.
And hopefully that, because a lot of questions we get asked as well is about the justifications when somebody's already got a wheelchair, like you said, Sarah. Well, why do they need alternative seating?
Yeah.
Rebecca, I feel so strongly about that, because my answer to that is always, how many pairs of shoes do you have? Yeah. Because we have different pieces of equipment for different, we understand that we need different pieces of equipment for different functions. And it's absolutely, people have enough challenges in their lives without having an alternative to the one seat that they've had during the day. We have to, changing, I've just put into the presentation, into the chat, there's a Twitter chat on Monday night that's being led by Changing Our Lives, who take a rights-based approach to postural care provision. And I think we need to start thinking very carefully about people's people's bodies aren't just mechanical things, are they? People are bigger than that, and we need to get really good at advocating some of the kind of more humane approaches to this sort of thing.
That's how we achieve our clinical objectives, by being holistic and making sure it fits into daily life for those individuals.
Absolutely.
It negates all our hard work if actually our clients don't want to use that piece of equipment, or support network don't want to use that piece of equipment if they're not comfortable. And that's one of our key things with seating, to be comfort.
Comfort and compromise.
Comfort.
Melanie Stevens and Carol Bartley presented at the International Seating Symposium in Nashville when I was there a couple of years ago, and that was the number one finding of one of their pieces of work, was that if someone's not, that's the primary thing, comfort.
Yeah, that was actually on our hydrotails.
Yeah, absolutely, it was. Yeah. People aren't comfortable, they aren't going to use it. Brilliant. Thank you so much for having me.
Thank you for joining us.
Thank you for everything. So with that, we'll bring the presentation to an end. Thanks everybody for taking time out of your day to join us. I'll repeat myself again, we will get you copies of the presentations and a recording of the presentations as well. Thank you for your time.
Thank you very much.
It's almost a weekend, we're almost there. So have a lovely rest of the day and enjoy the rest of the week. Thank you very much.
Thank
Bye-bye.
Bye.